Good morning, everybody. Thank you for joining us today for our webinar, Approaches to Treatment Planning and Case Management for Mental Health Diversion. My name is Ashley Brett, and I am part of the team at the Department of State Hospitals working on our mental health diversion program. We're very happy you could join us today. I just have one really quick ask of everybody who is on the line. We are muting participants as you call in or log in through your computer, and we do ask that if you are not one of our facilitators that you remain on hold just so we can limit the amount of background noise during the webinar. And with that, I'd like to turn this over to our facilitation team, which is being led by Hallie Bader-Tao of the Council of State Governments Justice Center.
Thanks, Ashley. Good morning, everybody. It is wonderful to be gathered together virtually to talk about treatment planning and case management. Before we hop into the meat of the conversation, I just wanted to do a couple of housekeeping items. As we said in the announcement for this webinar, one of the things that we've heard from counties across the state is an interest in hearing from each other and from others who are in a similar role to you. So while we're not physically in the same place, we are hoping that this will be a conversation that is responsive to the questions that you have, the challenges you're facing, and the successes that you're seeing in treatment planning and case management. So there will be a couple of times throughout the conversation where we will be asking those of you who are interested in speaking up, sharing who you are and any questions you had. In order to make that work through WebEx, what we're going to do is have folks raise their hand. So next in the participant panel of the screen, next to your name, there should be a little button with a hand that says raise hand. And if you click that, like I just did, your hand will go up, and that will help Ashley know that you're interested in speaking. And so she will move through the participant list and unmute people when their hands are raised and it's their turn to talk. If the raise hand is not working for you, or if you just want to get your question out there, we also have a chat function at the bottom of the participant area, or it's called a chat area. You see there's a little tile bar there. You can chat to everyone, or you can chat to Ashley with any questions, and she will either call on you to provide your question, or she will read the question out loud for all of us to answer. All right, I hope that makes sense. Let me just see if there was anything else in terms of housekeeping. If we don't have time to respond to all of the questions, we will certainly do our best to either incorporate them into a future training event or provide follow-up information after the training today. Ashley, can I get the next slide, please? This training is brought to you today by a partnership from the state of California. A lot of great people have been working on bringing training opportunities to California counties working on mental health diversion, including Ashley and her team at the Department of State Hospitals. And this webinar is sponsored by the California Council on Criminal Justice and Behavioral Health, which has been one of the core partners in sharing information about mental health diversion and providing training and outreach to different stakeholders across the state. We have a little slide here about CCJBH, but they are definitely interested in hearing from you about your experiences with mental health diversion and what would be useful for you as you're working on diversion efforts. Can I have the next slide, please? So myself and my colleague Rachel Lee, we're from the Council of State Governments Justice Center. I'm calling in from San Diego. Rachel's calling in from New York. CSG is a national nonprofit that combines the strength of a membership association with research and data-driven strategies. And our goal here is really to provide state, local policymakers with relevant research that they can apply locally. So we work with communities around the country as well as here in California on a variety of issues, and this project is within our behavioral health team. Next slide, please. So our order of operations for today's web meeting, we'll do introductions, and I am going to ask, it looks like we have a manageable number of people to try to go through and introduce ourselves on the phone. So I'm going to ask folks to say your name, your role, and a question that brought you here today around mental health diversion and case planning. We're going to do a quick refresher on collaborative comprehensive case planning. And then we're going to talk about a hypothetical diversion case and how you might think about different resources for case planning for that individual. And then we can address any questions and concerns you have and also hear from our expert presenters about how they approach case planning in their jurisdictions. Next slide, please. So there I am. My name is Hallie Fader-Tao. I'm a program director with the behavioral health team at the CSG Justice Center. I live here in San Diego, and I've been working on, I've been at CSG for just over 10 years, always working on the intersection between the criminal justice system and mental illness, often with an emphasis on the role of the courts in making connections for people with mental illnesses to community-based care. I've also been very involved with the Stepping Up initiative, both here in California and nationally. So I'll turn it over to my colleague Rachel to quickly introduce herself as well.
Thanks, Hallie, and hi, everyone. Thanks for inviting me to be on this webinar. My name is Rachel Lee. I'm a policy analyst at the CSG Justice Center, and prior to joining the Justice Center, I provided project assistance to several recovery-focused substance abuse and mental health services administration initiatives. I also have some experience providing therapy to people with behavioral health needs in both inpatient and outpatient healthcare settings.
Thank you. Can we unmute Eric and Leanne so they can introduce themselves?
Okay, I'm Eric. Good morning, everyone. It's good to be with you. I'm excited to be on the webinar with you. My background is that I am trained as a licensed counselor, and I started my career years ago managing assertive community treatment teams here in Idaho. During that process, we started mental health courts here in Idaho, and I currently am the district manager for our mental health courts in this district, and I manage 5 different mental health courts. Most of them with adults. We actually have 2 juvenile mental health courts also that we work with. So I've been doing that, and I've been doing some trainings around the country with the Council of State Governments for, I don't know, a lot of years, 15 or so years, and I also do a lot of drug court training with NADCP and the NDCI program. But I'm excited to be with you here today.
Thanks, Eric. Leanne?
Hi, everyone. I'm hearing an echo. Let me try something else. Can you all hear me now?
Try again, Leanne. I just unmuted another one for you.
Okay, is this better?
Yes.
Can everyone hear me?
Sounds good.
Okay, great. So hi, everybody. My name is Leanne Sharp. I am currently the Senior Director of Court Services at a nonprofit agency called CASES. It's the Center for Employment Center for Alternative Sentencing and Employment Services in New York City, New York. And we're an agency that specializes in helping folks at the intersection of mental health and criminal justice. We're a pretty large agency. We operate a large behavioral health department, including an outpatient state licensed clinic, as well as I think we're up to about 9 mobile treatment teams, which would be assertive community treatment and forensic assertive community treatment teams around the city, as well as my department, Court Services, where we operate a myriad of alternative to incarceration and detention programs. All of which, our folks are people who have, most of whom who have histories or current issues with mental health, who are also with us on some kind of a legal mandate. And then we also have another department. It's more geared towards our youth participants. Some may or may not be currently involved in the justice system, but we do a lot of high school equivalency, preparation and testing, job placement and assistance, internships, mentorship, and things like that for some of our younger folks. Prior to coming to CASES, I worked as a mental health clinician and supervisor at Rikers Island Correctional Facility for a number of years. And so I have both direct experience, individual and group, as well as from a sort of agency administrative perspective as well. And I'm glad to be here.
Great. Thank you both. Obviously, neither Bonneville County nor New York are here in California, but we wanted to take advantage of using one of the benefits of having a webinar is that we can bring in outside experts relatively easily. And so Eric and Leanne obviously work in very different types of jurisdictions. I don't think I'm saying anything surprising to say Bonneville County is different from New York, but we wanted to have them share their experiences with treatment planning and case management for these populations, so you can hear a little bit about how very different types of jurisdictions bring their resources to bear. And I think that we'll hear that there are some commonalities in good treatment planning and case management, whether you're in New York, or in the area around Idaho Falls. So moving over, Ashley, do you think that we can logistically have folks introduce themselves, or do we have too many?
I think we might have too many.
Okay.
Quite a few folks.
Okay.
Today.
If folks could take a moment and go down to the chat area and type in your name, your county and role, and one question that brought you here today. I think it'll just be helpful for us to know which counties are represented here, as well as some of the key questions that brought you here today, so that we can make sure to be responsive to that in our comments. So I'm going to wait a moment and give folks a moment to type in their name, their county, and a key question that brought them here today.
So they want you to chat and put your information.
Yep. So if you can use the chat function to put in your name, the county that you're from, and if you have a specific question or concern that brought you here today. If you're struggling with something, or if you've had a really great success, we definitely want to make sure to address that.
we good? No.
Great. So I'm seeing a real variety of counties here, from Los Angeles to Placer, a lot of interest in just hearing about what others are doing, getting some basics on treatment planning and case management, interest in creative treatment planning with limited treatment beds and resources. So Eric and Leanne, I bet you've both encountered that you don't have as many resources as you'd like. So how you think about prioritizing those and learning more about what others are doing. Okay, give this one more minute and then move on to the next slide. All right, thanks, Ashley. If you can advance the slide. Okay, so the first piece that we're going to do here is an overview of collaborative comprehensive case planning, which rolls right off the tongue. If you can advance the slide. Our group here at CSG developed the collaborative comprehensive case planning tool as part of our work for the National Reentry Resource Center. And the idea with the tool is that good treatment and case planning are going to involve not just one agency or department. There's going to need to be input from numerous stakeholders about mental health treatment, substance use treatment, housing, community supervision. And we realized that jurisdictions were struggling with how do you take all of that information in a comprehensive way? How do you coordinate those partners in a collaborative way? And how do you organize the information so that it is really coherent and meaningful to the person who's receiving the case management? Of course, also we wanted to incorporate what we know about what works in terms of mental health treatment, substance use treatment, and applying the risk need responsivity model to increase supervision for those who are at the highest risk of recidivism. So the CC Case Plan tool is a web-based tool that includes information about how jurisdictions can lead a planning process for collaborative case planning and organize that information. Next slide, please. I think this is a really cool, I call this the rainbow wheel. So the idea here is that a collaborative case plan will have inputs from a lot of different sectors, and that's the rainbow you see around the lead case planner who's bringing in that information and synthesizing it so that it is appropriate for the person who's being supervised and responsive to his or her needs. Next slide, please. If you go online, this is what the web page will look like, and you'll see that you can expand each of these sections so that you have in each of these 10 priority areas information about how different jurisdictions are implementing collaborative case planning. If you're interested in more information about this tool, we did a webinar on it with Department of State Hospitals and CCJBH this fall, and that should be available soon on the DSH website. We also have an archived webinar about this tool that was done not in the California diversion context, but nationally, if you'd like to learn a little bit more about how this tool works and what it can look like to help you think about your case planning for mental health diversion. So I'm going to turn it over now to Rachel to introduce the discussion about hypotheticals.
Great, thanks, Hallie. So on the next two slides, we're going to take a look at a hypothetical defendant to think through how practitioners, such as yourselves, might approach case planning and case management. So we can anticipate that this hypothetical person, Roger Mills, may have some of the same needs as some of the defendants you are considering for mental health diversion in your counties. So before we turn it over to the panelists for their thoughts, we will give you a few moments to read the next 2 slides, and the first of which contains information about the instant offense, and the second slide touches more upon information you may have ascertained from some form of a biopsychosocial assessment. So we'll give you a few moments to read this.
So maybe Eric and Leanne, just looking at the information that comes in from the arrest, what are some of your thoughts about, as you're thinking about this, what sort of assessment information might you want to get about Roger? What are some of the things you're thinking about in terms of his criminal case that might impact how you think about case management? And then we'll look some more at, we'll flip the slide and read what the assessment information pulls out that helps you do your case planning. So Leanne, can I go to you first, just to talk about any initial thoughts you have based on what's on the slide right now about his criminal history?
Yeah, sorry, I'm just still reading through it, I think. So I think one thing that I would want to know, I don't think I read is on here, is, as you said, his legal history would just be something that I would want to know in addition to the instant offense, because that certainly would come into play in terms of sort of bargaining what kind of a deal or an outcome he might be offered. And I also think it's, it's also very telling. It really provides a lot of information, I think, to look at, a person's legal history, rap sheet, and sort of see how many arrests, how much time between arrests, what the offenses were for, or I guess I should say arrests and or convictions. Um, um, and so I think sort of all of those things together, which certainly the legal parties are going to be taking into account. So I think that, the supervision or program agency should probably be aware of those things as well. So that's sort of my first thought. And as you say, I would want to know a lot more that we would be, as sort of behavioral health professionals, looking to ascertain in terms of a psychosocial assessment and things of that nature. I think one thing that comes to mind is the setting. And so I think what kind of information and how much information you're able to get do also depend on the setting. So like, for example, a lot of our staff are in arraignments, for example, and are having to interview folks in the pens behind the court. And so the kind of information we get is going to be sometimes different than what we may get when we're in a more appropriate clinical setting with somebody, when there are not, correctional staff around or other people that can hear their conversations. So I just sort of say that because I know everybody is kind of coming from a different place, but that's something that we definitely consider and we're sort of try to be sensitive to as well. Those are sort of my first initial thoughts. Not sure if you had more specific questions, but yeah.
Yeah, no, that's great. And Eric, is there anything else you would add, or how the assessment information might be different in Bonneville County? Sorry, the assessment context might be different in Bonneville County?
No, I mean, everything Leanne said, I agree with. The only things I would add, not to be repetitive, that we would look at a little bit when we're initially looking at this is, and we'll need more information, but one of the main things we're looking at with his, obviously the substance abuse piece is, what level we're going to need, what level of treatment we're going to need. Is this more of a severe end, which I'm assuming, or we're on the milder end, which used to be the dependence or abuse. We're kind of looking at that. The other thing I like that we'll look at or be looking for when we see his list of charges, when we get those, is we kind of take this as a framework of how we put it into the LSI, the level of service inventory, which is our criminogenic risk assessment, to work on those areas. So some of the things we're going to be looking for is, are most of his charges or all of his charges, drug related, or are we going to see some other things like we typically see, like do we have some DUIs or DWIs in there besides the regular drug charges? And the other thing we see a lot of that we'll want to be aware of is if we have any, domestic violence or previous no contact orders, things like that, that may lead us to know what we need to do with some of the, those family marital relationship issue pieces. Those are just some of the things we'd be watching for in addition to what Leanne mentioned.
Great, thank you. Ashley, can you advance the slide and let us know what might come out of that biopsychosocial in terms of assessment information? All right, starting with Eric this time. So obviously we have a lot more information. What are some of the needs that you see coming out of this assessment information, and what are some of the types of resources that you might think to start tapping to put together an appropriate treatment plan and case management strategy for Roger?
Okay, so typically how we look at this is we look at it from a couple different angles. One of the things that we often look at right off the bat is we have a little saying that we say meds, money, and housing. So if we look at Roger here and we say, where are we at with meds, money, and housing? And those are all responsivity issues, but we approach it from the stance that we need to help with those responsivity issues first before we jump into our, those central 8 risk factors to address those. And if we look at him, obviously we've got to address the, the homeless and where's he going to live situation, which ironically, I haven't worked with Leanne that long, but I've worked with her predecessors before. And I think whether you're in California, New York, Idaho, no matter where you're at, that's an issue. So we typically have housing folks that are really part of our case management team on every case that we deal with. And obviously there's a mental health piece to this with the medications and trouble getting them filled. So we would typically look at, where's he getting his money, or do we need to help him figure out, disability of that piece, the medications, and where he's going to live. Those would be our top 3 priorities. And then as we move forward, then we would look at, we would kind of go into those central 8. And obviously the first one we would look at would be the substance use and getting him in that appropriate level of substance use treatment, which in my opinion, having worked with a lot of folks across the country, I think we typically do a pretty good job at that. So I guess that part comes, at least in our area, pretty easy to do well at that. Then our next approach would be, how do we address the other pieces, that are part of that central 8, the work, education piece, the family relationships piece, and typically those relationships in our experience are one of the bigger things, especially probably in Roger's case, the relationships he has probably are leading to his, remaining in the system and part of that incarcerated 30 times prior. So, but we obviously there's a lot to pick out here. So we'd want to go kind of meds, money, housing, and then one thing at a time to address those other pieces.
If I can just follow up on the third of those, the housing, because that is such a challenge across the country. When you talk about having housing folks on your case management team, like who are those people and what sort of housing do you have for people who are involved with the justice system with behavioral health needs in Bonneville?
So that's a great question. What we did, what's pretty interesting here, Bonneville obviously is not near as big as New York, but it's actually bigger than some of our other rural parts of Idaho where we have courts. So in Bonneville, we actually have 3 or 4 different agencies that provide either crisis or transitional housing. And we actually have them as part of our weekly staffing that we do, because it's almost a given that the folks that come in almost always have nowhere to go. So it's pretty easy for us there to at least access either the crisis or the transitional housing, and that we just plan on it. We've done specific contracts with them to hold beds for us because we continually have people coming there through the court system. Not to take too long, but a different challenge that we met in some of our more rural areas that are smaller, we didn't have any housing there. So one of the things that we've done there is we worked with the county there, and there was no crisis or transitional housing at all. So we actually got the county to actually, the first time we did it on a grant, and then the county funded it, but we actually rented a duplex that was actually right across from the courthouse. And we were able to use that and put, 2 or 3 individuals in each side of a duplex to have that available for crisis housing. And that worked out so well. It saved so much money from wherever they were paying, to keep folks either in jail or in the hospital and have a place to go, that in one of the areas, the county actually ended up buying 2 duplexes and expanded that program. So those are just a couple outside the box ideas that we've done.
Great, thank you. Leanne, if Roger were in Manhattan, what are some of the things that pop out to you in terms of needs for case management and some of the resources that you'd want to bring to bear in his treatment plan and his case management strategy?
Hi. Yeah. So, wow, so many thoughts. I agree completely with everything that Eric has mentioned, certainly with housing. And I guess on that note, I'll sort of work backwards in my thoughts. Definitely housing is always, almost always a factor for sure, as it is for almost probably everybody on the call here. It's definitely a challenge in New York City. We have a severe shortage of housing. We often have people who are in shelter, a lot of people who are street homeless or in some other way unstably housed. And so I guess, I can sort of provide an example of how I might sort of walk through this. This sounds like somebody who would very likely be in one of our programs. It's a short-term alternative to incarceration program. One of the things that came to mind for me is how long you will have to engage this person. And so, everybody is sort of coming from a little bit different of a position. If it's like he sent to you, if this is part of a legal mandate, as it would be sort of for us, it would be how long is the mandate? Or if he's coming to you voluntarily as a service in the community, then, sort of you're also still thinking about time though. How long do you have this person? So one of the biggest challenges that we've found, and certainly in a case like this with someone who has a pretty lengthy legal history, lots of the offenses are low-level offenses, is homeless, has substance use and PTSD. There are just a lot of things here going on. For us, we found it really helpful not so much to jump into a full-out assessment. So again, it really sort of, I think, depends on how long you think you have to engage this person. We have, for example, programs that are really short-term. Alternative to incarceration programs, this is almost the exact profile of somebody we would have that goes into this program, where the legal mandates are literally, between 1 and 5 sessions. And then they're done. And so the time in which we have to engage someone is very limited. And what we found is, and certainly for folks who, the higher risk and the more needs people have, the less likely it is they are going to consistently follow up with us. And so what we found is, rather than really trying to do a full out, psychosocial assessment, that's not what we're aiming for in the beginning. We're really, our first and our foremost priority is engagement. We want to try to engage this person, really help him find a way to meet his most basic needs. And you can sort of even think of it as you're thinking of like Maslow's hierarchy of needs, right? Like, you're never going to get to mental health or substance use with a client if they're not appropriately housed or have food or have clothes. And so those are the things, like really concrete, immediate needs, that we focus on first and foremost. And we've found that it really helps to increase the chances that the person is going to stay engaged with us in the first place, so that we can later get to longer term goals like linkage and connection to mental health treatment, substance use treatment, and housing. And so those, I think, are some of the first things that come to mind. Certainly, if you have this person for a longer period of time, you definitely have more of a luxury of time where you can get to more of these things. But even so, I would still suggest really concentrating on the very basic, concrete, immediate needs first. And then once you've got, you're able to sort of offer something, to give something to your client, that really helps in the engagement process. And then I think can really help to further create a more genuine and open therapeutic relationship, where you can get to some of the more substantive stuff later on.
Great, thank you, Leanne. For the folks who are on the WebEx, if anyone has any questions, can you raise your hand? Questions or comments about either what Eric and Leanne mentioned in terms of the case management in their jurisdictions, or concerns you might have about handling this case on diversion in your jurisdictions? So if you look next to your name, there should be a little icon with a hand. If you could raise your hand if you have any questions or comments, or, wow, that's never the way we would do it here. Okay, I'm curious if you can, by a show of hands, how many of you feel like you would have the capacity to do case management for Roger in your jurisdictions if you were recommended for diversion? Ashley, I don't see any hands. I don't know whether that's that the hand raising is difficult, or nobody feels like they could case manage this individual.
I'm seeing about 5 hands, I believe.
Oh, okay, great.
So I am seeing these.
Okay, super. So if folks don't mind, if you're able to, if you're willing to share a little bit about what this would look like in your jurisdiction, if you can leave your hand up, and Ashley can unmute you so you can share a little bit where you're from and what case management would look like for you.
All right, I'm going to start, and there isn't a name for this individual. It is user E456116. why don't we try Garth Turner?
Yes, hi. Yeah, we actually have an individual who is this person, similar history. And when we go through we have 2 court clinician therapists that do the screening that takes anywhere from 30 minutes to an hour in the courtroom, in the jury room, in privacy. And so they're usually willing to share more information. And we approach the case management the same way. We get those basic met first. That's like a default for us. So our biggest delay is finding that housing and getting them out of custody. We don't release anyone on a court order for the program until we find that housing first. So yeah, that's pretty much the same way we'd handle this case. About it.
Great,
All right,
thank you.
and that was from, I was just going to say that was from San Luis Obispo, right?
Yes.
Perfect, that's what I was about to ask. Okay, we're going to go back up to E456116. And if you have another login, if you can chat that over to me so I can find you in the list. Or if you were a call-in user. Okay, Diana Perez Johnson, I don't know that I see you on the list elsewhere. Is your computer on mute? So why don't we, if you don't mind, Diana, if you, I want to move on to somebody else who has their hand up just so we're making use of the time while we try to, maybe we can sidebar and try to figure out what's going on with your sound. So give me one moment. Okay, the next individual with a hand up is, I believe, our friend from, might be, it is R or Beta. And it looks like these are folks calling in from Bakersfield, from Kern County. And if you can let me know if you, if I call on you and you have called in using the telephone, that would be helpful because it may be that I've unmuted your computer, but you are a call-in user, so your phone connection is still muted. Okay, why don't we continue down the list? I have a P-L-I-P-E-L-T with your hand raised. So if our folks who have joined, if you are listening through your computer but you do not have a microphone, we won't be able to hear you. So I would recommend switching your audio to phone. That way you can call in and you can speak to us as well as hearing the webinar presentation. Would anybody with their hands raised like to chat in their thoughts to us?
So while we're doing that, I can pull some questions back for Eric and Leanne, just to talk a little bit about how you've put together case planning in your communities. So maybe I'll start with Leanne and then go to Eric. Who are the key partners for case planning? Like who comes to the table? Who's the one who is leading the conversation and managing case planning? And as a reminder, in California, we're working on implementation of a new mental health diversion statute. And so for most of the people who are on the phone, they're going to be thinking about pre-plea mental health diversion that's available for either misdemeanors or felonies. So Leanne, who's at the table in New York for case planning? What are some of the key partners, and how do you get people together or coordinate the information that's going to go into the case plan?
Hi. Yeah, so I think sort of following this model that you had referenced, collaborative, comprehensive case planning, and in your diagram, this sort of nice rainbow circle diagram that you showed, which I think is really helpful. That is pretty much the way that we're operating. And so we do have, it would be really like a lead case planner, the person in our program that the participant sort of is assigned to is responsible for, would be the person probably who's doing a psychosocial, who's doing a full risk and need assessment, prioritizing sort of what the goals for the program or the treatment are. And it'll be the same person who then is reaching out to any sort of providers in the community that we need to collaborate with as well. And so we're really sort of operating from a model that there's a, sort of single person point of contact, and who's managing all of these sort of peripheral third-party providers and agencies and stakeholders. And so, obviously it will depend on the person, but for us, it's a little bit different because we're a nonprofit social service agency who is the supervision provider. One of the stakeholders would in fact be the court, or the defense attorney, and the prosecutor's office, and then as well as any sort of community treatment providers, housing provider, medical provider. And so you're sort of going around the list that you have in your diagram. That person, the case planner, then, is sharing information with the rest of the team. And so I think sort of Eric can speak very well to how this kind of works in an ACT, a sort of community treatment model where, a person, it may not be assigned to one single case planner. The sort of whole team is responding to the participant. So we do that in other programs as well. It sort of depends on the program that we're talking about. But in any case, the defendant really has a point of contact, though, where they have a person who's really helping them to organize all of these different sort of peripheral agencies and contacts or health providers in the community that helps them to keep everything sort of organized and intact. And then on our end, on sort of, just the court or reporting end, obviously we need to know what is going on with the defendant's participation in any community providers programs or things like that, so that we're pulling all the information together so that we can appropriately report it to the court.
I was just, that it's I appreciate your ending there, because I know that a number of the places that are setting up diversion programs in California, you might have community-based organizations or treatment providers or others who are reporting into the courts for the first time. Is there any sort of tricks or strategies you've learned about how to make that an effective relationship where the courts are getting the right amount of information that's useful for them, and it's also, using your time well in terms of preparing reports or appearing in court?
Yeah, that's I think it's a question that everyone probably, sort of certainly going into this, but it's something that we still work to try to achieve a really good balance is you know a sort of social service or behavioral health agency is looking at this maybe with a slightly different perspective or agenda or priority than some other stakeholders like the court. And so I think for us, it's been really important to train our staff to look at things in as neutral a way as possible. We are trying to advocate for people. We don't want people in the system, and it is our job to report truthfully what's been going on with the defendant. But at the same time, we're also trying to highlight the strengths as well. And I think that's just important because a lot of times, and I think just even historically, courts have been accustomed to sometimes more sort of punitive ways of receiving information, and so this might be a change for some people in some of the jurisdictions out there. But I think so what's really important is, we're operating from a strengths-based perspective, and while we're reporting on whether there's non-compliance at all in a person's participation in the program or with the mandate, we're also ensuring that we're highlighting what things have been going well also. And so I think that's just important. It really is sort of the way that you are presenting the information as sort of comprehensively as possible really helps. And in that way, you're working well with all the stakeholders. I really think that transparency is key. And so, you're sort of satisfying, things with the defense as well as you are with the prosecution, who all need to know what's going on, but you're presenting a really comprehensive, holistic view of the information, and just ensuring that, that you are making sure that you're not just presenting on the non-compliance, you're also relaying, things that have been going well, and sort of that way you can put a different light on things. But I think it doesn't sway it. It just really does ensure that you're presenting in a really holistic, comprehensive way.
Great, thanks, Leanne. And I'm going to ask Eric to answer the same questions and also give for the folks who are joining remotely, if you have any questions for our panelists, to chat those in so that I can make sure to ask those. So Eric, same sort of question, and either for Bonneville County or for Bonneville and a more rural jurisdiction within the 7th District, who's involved with the case planning, who takes the lead on it, how does that come together?
Okay, so I mean, Leanne said that very well. So not to repeat what she said, I'll just kind of piggyback on what she said. And she mentioned we have some folks that meet at criteria here, which is awesome if they do, because that's kind of the Cadillac of a case management team. If they don't, it's like everywhere else, we're going to link them, to services to a treatment provider. And we have all the same people and really use the same approach that Leanne mentioned. The one person that we do have besides housing typically at the table is our vocational rehabilitation folks are typically there at our table, which is pretty helpful for us. The one thought that came to mind, so you can divert me, Hallie, if you want, but as I was thinking about setting these up, when we first set up these programs with our courts, one of the things we ran into with our providers that aren't used to necessarily working with the court system, we had two responses that we have to work through. Some of them did it just great. Some of them are so frustrated sometimes with working with individuals like this case plan here. Roger, I think was his name, how we did that. They're so frustrated with trying to engage and doing that and not having any accountability for those folks that some of them are so excited to have the legal system involved that they got a little overzealous kind of in reporting and not staying in their role and needing to stay positive and strength-based, like Leanne mentioned, and working with the system that way. They almost got overzealous of, he needs some accountability for these things. The other side of that, if I look back at when we started, that's sometimes difficult for treatment providers is some treatment providers are happy to have some accountability for the participant, but they're frustrated with any accountability for them. So it was hard for them if we'd gather information and they'd say, well, so-and-so, Roger missed this appointment and that appointment. But sometimes it was difficult to get information from them, or they canceled appointments and things and wouldn't share that information. So it's important that there's really good communication there and a really good balance. And in our experience, that takes a little bit of time to get that right with some of the providers if they're not used to working with the court system.
Great, thanks, Eric. Leanne, I know that one of the things that you do at cases is managing individuals charged with felonies and some serious felonies who are being released to the community under conditions of release, including, working with your team. Can you talk a little bit about what has led to success with working with felonies? I know there's generally a lot of anxiety about taking on that population pre-adjudication.
Yes. So we have a number of programs where we are taking folks charged with felonies. Some of them are not pre-adjudication, some are post, and it is a part of the mandate. But others, including our very quickly expanding pretrial supervised release program, is open now to almost all felony charges as well. There are very few exceptions, which is consistent with our very new changes to our bail statute that went into effect on January 1st. And so prior to January 1st, it was a less extensive list of charges. We weren't taking violent felony charges, for example, but that's sort of changed now. Again, there are very few exceptions. And so what we sort of did, and this is not entirely decision that cases did, as part of this sort of in collaboration with the City of New York Mayor's Office of Criminal Justice, as well as with the prosecutor's offices and the defense bar, we sort of all have come together to discuss what, everyone is sort of willing to sort of put in, to sacrifice, to, and on the other end, what they're sort of not willing to give up. And so that was, I think, has been one thing, not just in this instance, but in others. One really important thing is having stakeholders from all sides of the table at the table where you're talking about these things together. And so for us, in that way, we've been able to sort of develop these sort of policies together. And we've divided the sort of response or the supervision level of supervision into two different tiers. And so it may be based on the level of risk. It may be based on the instant charge, if it's a violent charge, that may call for a higher level of supervision. I'll sort of just say that generally. One of the things, though, that I think is a cornerstone of what we do is that we deliver services in the community. It could be, and so much like an ACT team that is delivering services, seeing clients in the community at their homes, at the coffee shop, at the library, grocery store, wherever, instead of mandating that folks come into the office to be seen, makes a really big difference. And so I think, we're sort of approaching, and so that has trickled over to almost all of our programs now, where we try to accommodate people by meeting them literally where they are in the community, if we need to. And so I think, that's just something that's really important to think about. Again, to my earlier point, it sort of links back to engagement. How are people, sort of successful in these programs, especially those who are charged with more serious offenses, is really developing a really good platform of engagement and trust. And so if it's that if it's convenient for somebody to come into the office, that's fine, we can do that. But otherwise, there's nothing our philosophy is that there's nothing that we're talking about we can't talk about outside of the office, outside of the four walls of our office as well. And in many cases, it only helps to build engagement and trust and rapport with our clients. And so they're willing to stay sort of more engaged. They're more willing to open up and sort of go through the process with us. And so I think that's really something that I would stress. It's not, a lot of places don't have the capacity to do that. And so I think that's just something for sure that I'm sensitive to. But it means that all of our staff, and so when you're looking at your staffing structure and who you have on board, it could be anybody sort of who's doing this, anybody who's working on your programs, who's delivering services in the office, probably could deliver service outside of the office as well. And it will depend on how many caseloads are and things like that. And if you can structure your program so that some people are able to be seen in the field, I think it makes a really big difference. In some of our programs, we rotate. So we may have staff who, some staff are in the office on certain days and others are out in the field, and they're trying to track down people who may have gone missing, who may need a little bit more hand-holding or engagement in the field, and can kind of balance things out that way as well. So that's something that, may or may not be, I'm not sure, a little bit more unique to sort of the way that we do things at Cases, but it certainly has made a difference for us in terms of not just for felonies, and even interestingly, Hallie, to your point, it's funny that actually those charged with less serious offenses are sometimes the harder to engage. We're not sure exactly why that is. There's been some speculation. But like for misdemeanor charges, for example, which are, everything is changing for us now, but historically, sometimes people with misdemeanors were harder to engage, and it could have been, I don't know, because there was less at stake, or, because the charge was not as serious. And so it's interesting, but we have found that folks with more serious charges are in fact easier to engage and usually stay consistently engaged with us more often. But again, I think, it's important to understand what the expectations of the stakeholders are in cases that are more serious. Certainly court and your prosecutor's offices, and what, what they expect from you. And so I think that's just a really important piece to keep in mind.
Great. Now, that's a lot of good things to think about. Ashley, as we go to the last slide with resources, Eric, any concluding thoughts for the folks who are starting mental health diversion programs and thinking about who needs to be at the table or how to position the programs for success?
I don't know that I have anything to add. I think the couple things I would highlight from what Leanne said is that really stand out is the more you can engage these folks in the community, I do think that's much more effective. These type of folks, they really traditionally have a harder time showing up in the office. If you can meet them where you're at, it's much easier not only to engage them to get better outcomes. And the other thing I think I would just second that Leanne said that we've seen also is we actually have seen better outcomes with our folks with felony charges than we have with misdemeanor charges because there is a little bit more at stake and it is a little easier to actually work with those. I know the opposite is kind of true. People are actually more hesitant sometimes to work with that population, but we've actually seen better outcomes with those folks.
Great. Well, thank you both so much for sharing your expertise and your experiences from very different parts of the country with the group here. And we will certainly look forward to continuing the conversation with the California counties that have joined us today, figuring out maybe a different platform to make it more interactive across you all so you can hear from each other's experiences. But thank you all for joining us today. Thank you very much to CCJBH for sponsoring the webinar. Ashley, are there any final housekeeping items that we should do before we thank everyone?
No, I think we're good to go.
Okay, great. Thank you, everybody. Have a lovely weekend.